All right, let's get right into it. Dysphagia, which is just a fancy word for trouble swallowing, is one of those classic complaints you'll see again and again no matter what specialty you end up in. And getting that initial workup right is absolutely crucial. So that's exactly what we're going to break down here. So, when we say dysphagia, what do we actually mean? Well, the key word here is transit. It's a problem with food or liquid moving from point A to point B. This isn't about pain when you swallow. That's a whole other thing called odynophagia. No, this is either a mechanical problem, like a physical blockage, or a propulsive problem, where the machinery that pushes everything down just isn't working right.
So here's our game plan. We're going to walk through this just like you would with a real patient. We'll start with how a normal swallow works, then we'll hit the single most important question you need to ask. After that, we'll dive into how to decode the patient's story, map out the workup, and finally touch on the big ideas behind treatment.
You know, it's funny. To really figure out what's going wrong, you've got to first appreciate what goes right. A normal swallow is something we do thousands of times a day without even a second thought. But it is an absolute masterpiece of coordination.
Okay, just look at this. You don't need to memorize every single label here. Just take in how much is going on. It's like a perfectly timed relay race that happens in 3 phases. First, the oral phase. That's you consciously getting the food ready. Then, phase 2, the pharyngeal phase, kicks in automatically. Everything closes up to protect your airway, and whoosh, the food is on its way. Finally, the esophageal phase takes over with this wave-like contraction that carries it down to the stomach. A breakdown anywhere in that chain, and you've got dysphagia.
All right, now this is the big one. This is the single most important moment in your evaluation. When a patient says, "I have trouble swallowing," your entire diagnostic path, everything, hinges on the answer to one simple question.
Seriously, think about it for a sec. Your patient is sitting right there in front of you. What is the one thing you have to know to even begin to sort through all the possible causes? That's it. It's that simple. Where? You can ask. Where do you feel the food getting stuck? Or even better, can you point with one finger to where it happens? Localizing the symptom is the master key that unlocks the entire diagnostic algorithm.
And here it is, laid out for you. Don't worry about reading all the tiny print on this algorithm. Just look at that very first split right at the top. The entire pathway divides based on that one question. Does the patient point to their neck, like they're having trouble getting the swallow started? That's oropharyngeal. Or do they point down to their chest, like the food gets stuck after they've already swallowed? That's esophageal.
So what you're really listening for are 2 totally different stories. With oropharyngeal dysphagia, you're going to hear things like, "I just can't get it to go down," or "I start coughing and choking the second I try to swallow." You might even hear about stuff coming back up through their nose. But the esophageal story, completely different. They'll say, "Oh, swallowing is fine," but then it just gets stuck right here, and they'll point right to their chest.
Okay, so let's follow that path. Let's say your patient's story is pointing to an oropharyngeal problem. Your brain should immediately split into 2 buckets. Bucket number 1 is structural. We're talking literal plumbing problems. Maybe there's an outpouching called a Zinker's diverticulum, or a thin web, or maybe a tumor or scar tissue from something like radiation.
Now, the second bucket is a whole different ballgame. Here, the plumbing is perfect. The pipes are clear. The problem is with the propulsion. It's a neurologic issue, more of an electrical problem than a plumbing problem. And this is when you start thinking about big neurologic conditions, like a past stroke, Parkinson's disease, or ALS.
Okay, let's hit rewind. What if your patient pointed to their chest instead? Now we're heading down that esophageal dysphagia pathway, and I'm telling you, this is where your history-taking skills are like a superpower. You can often figure out what's going on just by listening carefully to their story. This slide right here, this is pure gold. So your next question is, what kind of food gives you trouble? If it's only solids, like bread or meat get stuck, but liquids go down fine, you're thinking of a structural blockage. The pipe's just too narrow. But if they say, even water gets stuck, right from the beginning, now you should be thinking about a motility disorder. The muscle itself isn't working right. Then you can layer on the timing. Is it on and off, or is it slowly getting worse over time? And the source material gives us some absolute classic clinical pearls. You get a patient who's been chugging antacids for 20 years and now has trouble swallowing? Your alarm bells for a peptic stricture should be ringing. Or what about this story? Somebody who, a few times a year for the past decade, gets a piece of steak stuck but is fine otherwise. That is the textbook story for an esophageal ring. See? The history tells you almost everything.
Okay, you've done the hard work. You listened, you asked the right questions, and now you have a really strong suspicion about what's going on.
So what's next? Well, now it's time to prove it with some tests.
And the workup is super logical. You just pick the right tool for the job. If you suspect an oropharyngeal problem, an issue with the action of swallowing, you need to see it in motion, right? That's what a video swallow study does. But if you think it's an esophageal problem, a plumbing issue down in the chest, well, you got to look inside the pipe. That's a job for an upper endoscopy, or EGD. And what if the EGD looks totally normal but you still think it's a motility issue? That's when you bring out the big guns, esophageal manometry, which actually measures the muscle pressures.
So we figured it out, we have our diagnosis. The final piece of the puzzle is, what are we going to do about it? And the key thing to remember is that there is no one-size-fits-all treatment for dysphagia. It has to be tailored to the exact cause you just worked so hard to find.
The treatment just has to match the cause. If it's a neurologic problem, you'll be working closely with a speech pathologist, maybe changing the diet with things like thickened liquids. If it's a simple stricture or a ring, we can literally go in with a scope and stretch it open. If the problem is inflammation from something like GERD or eosinophilic esophagitis, well, that's a job for medications. And of course, for things like tumors, surgery might be on the table. The treatment flows directly from the diagnosis.
So let's bring it all the way back to the beginning. The next time a patient sits in front of you and says those 4 simple words, "I have trouble swallowing," you're going to know exactly where to start. The whole case, the whole workup, it all unfolds from that one simple localizing question. Can you show me where?